So this is the most exciting part of the afternoon. This is where you all get to ask questions. But first of all, can I call upon the panelists to join me up in the red chairs? We have 3 panelists who are going to kick off the discussion session. So next to me is Professor Mehul Mohtani. I hope I've pronounced, from the NUS Department of Electrical and Computer Engineering. His research interests include information and coding theory, machine learning, biomedical informatics, wireless and sensor networks, and the Internet of Things. Next to him is Dr. Tamara Lysart, Director of Research at our centre. Her work focuses on the ethical, regulatory and policy issues surrounding clinical translation of stem cell research, regenerative medicine, genomics and precision medicine, as well as data-intensive research. And at the end is Associate Professor Niam Ki Yun, Group Chief Technology Officer, NUHS, and Deputy Chief Medical Informatics Officer, NUH. His special interests are thyroid and endocrine surgery, robotic thyroid surgery, bariatric and metabolic surgery, advanced endoscopy and laparoscopic surgery. So our 4th panelist, Effie Villena, unfortunately has a family emergency and is not able to be here. But the good news is that Niam will take a couple of minutes to talk about some cutting edge issues that they've been facing at NUH. We'll then have a general panel discussion, and I'll invite you to give questions. And also I have my colleague, Victor Cole, who is the director of the SHAPES program, who will be co-moderating this. And he has the Mentimeter, which will generate questions from the virtual world. So without further ado, Niam, would you want to just kick off the session with a couple of comments?
Thank you, Julian, for this opportunity to share some of the work that we are doing in NUHS and some of the issues that have been discussed, debated earlier. I think I'd like to kick off by saying that this seminar is extremely timely, right? Because just as you know, everyone is talking about ChatGPT, and it's created a new hype. It's almost like a second wave of AI hype, right? That is warranted and unwarranted in some cases. And I would say that in the so many years that we've been trying to use AI in healthcare, this is the most unprecedented moment in AI, where ethics is now come right forefront, because people are now realizing that in a few minutes, hours, I can do what I normally do in months or years using something like ChatGPT. And many of the researchers that we know of that have been working in this area, Mehul and others, right, will know how hard it is to get to this point, right? And it's not just simply saying that, oh, okay, just run some machine learning and get some data. So we reach a point of the evolution of AI where I think these questions need to be answered, right? And the questions need to be answered are, as a community, whether in Singapore or in a global community, what is the consensus? What do we accept to be AI that is good enough for us to use both in healthcare and in other settings? At the same time, we have to balance that against all those risks that we mentioned earlier, bias and unclean data and so on and so forth. And then along the way, there are all these other processes that we need to put in place. So I guess the most important question as a community of the answer is, where do we draw the line, right? Where do we draw the line where this AI is going to be dangerous, potentially dangerous, balanced against its utility? And where does humans come in to regulate and stop and prevent some of these things from happening? So just the other point to mention is that many of us fall back on this human in the loop kind of considerations when using AI. So instead of just saying, okay, the AI makes its own decision, we always have a human in the loop to prevent any untoward outcomes or assign responsibility to the human. It's much like the autonomous car, right? We don't have fully autonomous cars because we want to have drivers to take responsibilities. But I think that day will come when these AI, and that's soon, right, will be autonomous. And when that happens, right, who do we assign responsibility to? I think this is the time where we need to answer that question. Okay, thank you very much.
Okay, thanks very much. Yeah, would would any of the speakers like to address that question or challenge that Niam's presented? Well, I mean, maybe before we go to the other panelists, I'll press perhaps Marcus to answer this one wherever he is. There he is. So, you know, there's the human in the loop, but then there's the human programming the endpoints or evaluating the outcome. So, you know, you mentioned this issue of futility, and Niam is questioning, where do we draw the line? Well, how do we define what is futile? So is it a probability of 5%? Is it a probability of 1%? Angela mentioned equality versus utility. Sometimes people give more weight to younger lives rather than older lives. So we'll accept an even lower probability for a younger life than an older life. I think she mentioned quality of life afterwards. There are a whole range of value judgments that Angela said we need to involve diverse communities in addressing. But is it just a matter of getting representative groups? I mean, how are we going to decide these sorts of lines? How do you decide them? How do you decide what futile is?
Yeah, thanks, Julian. So, you know, excellent question. And, you know, cardiac arrest, again, is probably one of the most difficult use case, you know, to apply some of these principles. On one hand, you have basically the individual kind of perspective, right? Where every life is precious. And, you know, maybe 30 years ago, you'll be considered ripe old age if you died at 70, let's say, you know, but today dying at 70 is premature death, right? And even if there was a 1% chance, you know, if I told you as your doctor, you know, you have cancer, you have a 1% chance to survive, you know, in the next 5 years, right? Would you opt for surgery? What if it was a 0.5% chance, you know, or 0.1% chance, right? A lot of people will still opt for surgery, right? Even if it's so-called futile, and there have been various definitions that say if you have a less than 1% chance of survival, that's futile, right? And then you have to balance that on the other hand with the public kind of good or the public health kind of perspective, where, you know, every case that you prolong life and, you know, you are having bed days in the ICU, you are, you know, consuming resources, and not just for the system, but for the family, for, you know, you're depleting your finances, what could be left for your children, for example, you know, and what if you survive, but with impaired neurological function and you are dependent on activities of daily living? Is that a good outcome? Is that a positive outcome? So I don't think there's a easy answer, but as I tried to hint at the end of my talk, it will require an alliance of both the patient, their families, you know, the actual, I would say our stakeholders, right? And the clinicians and the policymakers, as well as the scientists who are, you know, designing these algorithms to actually grapple with some of these issues and work out solutions that are socially acceptable, ethically acceptable, and even acceptable from a public health or clinical practice kind of perspective, right? And so I think this is just a sample of the questions that we are grappling with. I don't have any easy answers, but I do know it will take working together to do it.
Joseph.
If I can chip in my 2 cents, instead of answering the question where to draw the line, I think it's impossible to draw a line that crosses all disciplines in all scenarios. I think what we should ask is how not to jeopardize the doctor-patient relationship and how not to give up the autonomy of our patient as well as doctors to exercise their discretion in the decision-making process. I always like to use the driverless car as an analogy, that if you sit in a car which can drive by itself, that's fine. The system can be so safe and so efficient and detect all the on the street and so on. But something can happen, and you still need to have a steering wheel and a brake that you can make a stop and you can turn as you exercise your discretion. And we don't know when is that going to happen. And we cannot say it's always 5% or 7% that we need to make a stop. But I think the autonomy of the healthcare providers, as well as the healthcare receivers, they need to know that their clinical judgment and decision is partly machine and partly human, and which part is doing what. I think that is perhaps more important and more realistic.
But just to press you, so the apparent part of the reason why driverless cars will reduce sort of traffic mortality by 90% is because they can react much faster than a human being. So you won't have, in some cases, time for a human to enter the loop and brake and change direction. So what happens when you start to get, AI that is acting faster and more efficiently? I mean, do you think we can continue in medicine to keep humans in the loop?
Yes, you're right that machine can be faster and can be even more accurate than human decision. All right, but that doesn't mean that we should give up all our discretion. And a lot of surveys have shown that patients would like to have discussion with their doctors and make the final decision based on their feeling and their dignity being protected, and they feel that they are being respected. So it's not always a matter of probability and right or wrong decision and how fast the decision is to be made. I think the human part of medicine should be preserved.
Yeah, I was going to go to you next.
Yeah, so I think the question of where to draw the line is going to come up more and more. I mean, I agree with you that in some level, patients want to talk to doctors, but in the last few months, the AI landscape has changed significantly to the point that we may not be able to tell who we're talking to, right? So it could be that you think you're talking to a human, but you're not. So I think this question of where to draw the line is gonna be, more and more important. I think just thinking that, well, I mean, at some level, we've been addressing this question of where to draw the line even before AI, right? And I think it's just going to happen more and more. So not an easy thing for us to figure out.
So Tamara, you've worked with making decisions about drawing the line in relationship to genomics. Could you tell us some of the ways that we might think about drawing the relevant lines?
Well, just reflecting on, I think one of the speakers, the presentation before, made a really, really important point about what the goal of AI ought to be in healthcare. And I think if you're sort of putting at the center the purpose of augmenting human judgments and decision-making, not replacing it, and keeping the patient's well-being at the center of those decision-making. That is much what we expect of doctors in maintaining and protecting the patient-doctor relationship. And so I think that the same ought to be translated over into AI. Now, where should the line be drawn? I think that's going to be a very difficult question to both answer in theory, but as well as like implement into practice, because as the technology is changing all the time, so will, where those boundaries and lines that need to be drawn, they're also going to be sort of shifting. So I think within, any kind of system which is, aiming to implement and embed these AI decision-making tools, that there needs to be that sort of this ongoing reflection and consideration of actually how the systems are being used, taken up, and how they're affecting patient-doctor relationships and decisions that are getting made, and being responsive to issues that we just won't be able to foresee until they've been rolled out into practice, I don't think.
Okay, so Niam, do you have something to add?
Yeah, just to echo Prof. Joseph Seung's point, I would draw the line at full autonomy. That's how I see it in healthcare, at least, right? In many circumstances, I think if it involves human life, I think there has to be a human in the loop. That you can't have autonomous decisions from AI, because even if you're wrong 1 in a million times, right? That one time that the AI is wrong, there will be moral outrage, right? You think about it, that one time they're wrong, although they could be right, 999,000 times, right? That one time you're wrong, people will ask, why is a human not making a decision on life and death decisions?
Well, just to play the devil's advocate, I'm completely support that, but just to try to stimulate a bit of disagreement. Yeah, just imagine that, I find out that my parents are dead, but let's say my mother was here and the AI that Professor Ong described before made a decision to take her to a lower grade hospital and she died on the way. And I went to the newspapers and said, the AI killed my mother. They left this decision to an AI to decide which hospital. She should have been taken to a center with advanced cardiac resuscitation facilities, artery bypass surgery, etc. And the AI killed her. I mean, how would you respond to that?
Well, I think personally, that's where I drew the line, right? Which is I wouldn't let the AI make that independent decision.
Well, it is going to make the decisions. He just described how it will. I mean, presumably the point where the human comes into the loop is deciding which patients are going to go to which hospital, and that's the human in the loop, but then the AI operationalizes that goal. And in a sense, the AI is deciding, is that enough human in the loop, or do you want people to be able to override the recommendation of the AI on site, so they make a decision? Oh, actually, it's Julian's mother. We'll take her to the better hospital because
it's Julian. You're taking to a better hospital.
Wouldn't that be?
You're the ethicist, right?
So is that enough human in the loop? Sorry, yeah.
This is exactly what we're talking about. The line is not drawn at 5% or 7%. The line is drawn at the final decision has to be taken by the human doctor. I mean, even the computer, even the machines say that there's no hope, stop resuscitation. The doctors still have to take up the responsibility of accepting this recommendation. And instead of it is the machine's recommendation and executed as such. I think that is the difference. So 100% autonomy, even the patient's autonomy, the patient's right should be respected. He or she may not want to be resuscitated. Even the machine says so. All right. So I think that those are the important considerations.
So I think the challenge here is, as was pointed out, even if the human is in the loop, the information given to the human is by an algorithm. And in that situation, it's not clear who's making the decision. And I think that's the challenge. I think that was the conflict, I think, being brought up here.
So let me just clarify from the clinical perspective, right? That even today, we are making life and death decisions based on an algorithm. It's just that that algorithm was something that was taught to us in medical school or handed down as a tradition, right? Or something that we have, because of 20 years of experience, clinical practice or whatever, we have sort of like this algorithm or pathway in our brain. The main difference between this and, what we are talking about innovating for the future is that, ours is based on, not necessarily data or objective kind of evidence, right? And hopefully what we're trying to do is put more objectivity and, a data kind of driven decision making, right? And again, we are talking here about clinical decision support rather than autonomous AI making decisions for you, right? And which is why, for example, Leona and myself have spent a lot of time working on the explainability part of it, right? That at the end of the day, the clinician takes the responsibility for the decision making, and knowing full well that this AI recommendation is based on these criteria, this is the weightage behind it, and that's what's driving the decision making, right? And I think it's absolutely essential for the human to have a veto right, So if it was Julian's mother, for example, we might decide otherwise.
That's what I want to hear.
So there seems to be an implicit bias here that we're more comfortable with human errors than AI errors. And, and the comment was made, 1 in 1,000, 1 in 100,000, we can't accept that. But, Marcus just explained, medicine is rife with errors. So why are we more comfortable with a human making a mistake than with an AI making a mistake? At least with an AI, I can understand why that mistake was made. I can point to that mistake, learn from that mistake in the future. Ideally, that mistake is made not emotionally, is not based on my own prejudices, my own concerns, or my own discomfort, talking about end of life care or things of that nature. We're talking about, the questions of hospice. We can control the mistakes, right? I always have conversations with investigators. Tell me the kind of mistake you want to make, false positive, false negative. We can understand the rate that mistakes even will occur. So yes, mistakes will happen, but the mistakes are much more understandable with an AI tool. With humans, the mistakes are completely opaque. You have no understanding why that mistake was made. It's much harder to learn from those mistakes. People don't even acknowledge often that mistakes were made. So why are we jumped into this presumption that humans even ought to be in the loop?
Wow. What, do we have an answer for?
We are speechless. That's a brilliant point.
I think it's because you can sue a human and you can't sue a AI. You can't sue the software, right? Maybe the lawyers are going to step in now. That's certainly why I would feel, you can make someone, a person, an agent responsible for an error. I can't see how you can do that with a algorithm that's learning. on its
Okay,
own.
we have 5 minutes remaining, I've been told. Angela's been waiting the line. I saw Cameron's got his hand up, and then we've got mentees on the Mentimeter.
Agree that I think actually it's about liability. And I think we need to be thinking much more strategically about liability in the system. So are we going to have something like a medical FDA that approves apps and when they're used? Are we going to rely on medical negligence? Are we going to have something like we have in New Zealand, which is an accident compensation authority, which means that if you're injured in medical care, that all your care is covered. You could have something like a vaccine compensation fund. But that's really where we need to be thinking about how do we address the harm if it goes wrong. But the point I was going to make was this whole idea that we need the clinician in the loop. I think that's a very high income country perspective, right? How does it augment this clinical decision making? When you're looking at low and middle income, particularly low income country where there isn't access to healthcare, you're looking at community health workers, which is the best case scenario, or small business owners working with AI and telemedicine. So the whole, that whole kind of assumption that you've got clinical expertise in the loop, I think is problematic in low and middle income countries.
Okay, thanks. Yeah, good point. Victor, do you want to take one from the?
Thank you. This for me is quite an interesting question. Should we require RCTs or randomized clinical trials before deploying AI in the clinic? Much evidence on efficacy is observational. RCT can give robust evidence of clinical impact.
That's a great question. I'll start with that, but I think it's premised on one fact that I think which is the fact that AI by itself is usually not better than the human. That's the first thing, right? We've done randomized trials to address the other question to show that it's not better than humans. Most of the So the other point to make is that AI plus humans, better than humans, better than AI. So that is proven in some of the randomized trials and that's come out. So let's just talk about the point about what if AI and human is much better than either, right? That's an ideal situation, right? Where as a clinician, if I can use this tool to make me reduce my risk of making errors, I will use this tool, especially if I know the evidence, right? Which then brings us to the next point. You need to train the humans to use this tool properly, right? This is a tool, right? It's not a little human sitting inside ethicist, Julian sitting inside the computer, right? Telling us what to do, right? It's a machine. You need to know how to use that, much as you need to learn how to use scoring systems, right? Even if you knew what the scoring systems, what parameters they were, you still need to know why you are using those particular points, right? Or variables. And I suppose I put the last point here, which is very poignant, I would say. Years ago, I was asked to develop a tool that predicted death. I shared with Tamara. That was that long ago, right? 2018. Could we predict death in the ICU? And I said, I'll never develop that tool. I just told the ICU, I will never develop that tool. Not in my lifetime, I won't develop it. Because you can tell, right? This tool is going to be so controversial, so damning, right, to the human soul, right? And can you imagine the junior doctor going to the family and say, your mom's going to die because the machine said so. That's a death machine, right? Fast forward 5 years, there are now multiple trials that have been done on such tools. Trials, right? And the trials have shown that these tools advise what you call serious sickness conversations, right? So these tools help the clinicians, the intensivists, start those conversations with the family if they are used properly, which brings me back to my earlier point. You need to train the clinicians to use these tools properly. Otherwise, they'll be abused like any other tool that is out there. Thank you.
We run out of time. We got Cameron, I think you're another mentee. Thank you. Are there any questions from the audience here? Let's go take one.
Accommodate. Okay.
Last one.
Yeah, we've kind of been here before, so it's a little bit recursive. But anyway, when the AI makes a bad call, who should bear responsibility? The scientist, hospital, doctor, or fate? And what are the consequences of where we lay the responsibility?
So it goes back to the question of what we're trying to achieve. And I think this is clearer in some areas that we should delegate to AI. The less controversial, the easier. So spam or not spam, that's something that I'm very happy to delegate to AI. Whether someone's going to be resuscitatable or not, we're wary of. But I'm kind of fascinated by the denial of the fact that, I mean, a decision is being made. And one of the fascinating things as a non-medical person is the extent to which the law is completely divorced from the reality of medical practice. Because in theory, the law is very clear: patient autonomy, doctor-patient relationship, informed consent. But in reality, in practice, often informed consent is not very well informed. And there is a kind of magic associated with the medical process that is in denial that decisions are being made that will either lead to life or not life, or Julian's mother going to a particular hospital or not. And who we blame is in some ways secondary to the way in which that decision is being made. And I completely understand and sympathize with that denial, because it goes back to an very old sort of Kantian idea of ethics, that we don't want to treat people as means rather than ends. So someone should not be subject to a machine saying, you live, you die. And the challenge is these decisions are being made. But to try and answer the question, at the moment, the law is pretty clear. Doctor-patient relationship, it's either going to be the doctor or it's going to be the hospital. And for the AI provider, one real challenge is at the moment, and I defer to Cameron and others on this, my understanding is a lot of non-invasive, like non-medical devices that are advising the doctors, these are treated basically the equivalent as the doctor's knowledge or a textbook or Googling for information. When increasingly what's going to happen as the data gets more sophisticated, as the machines are faster, more autonomous, more opaque, the idea that the doctor is making the decision is going to be harder to justify, because he or she won't necessarily understand that. And that's going to make informed consent on the part of the patient next to impossible. So at the moment, it's pretty clear, doctor or hospital, but moving forward, you're holding people responsible for things that they either don't understand, or if they intervene, would only be slowing down the decision that could actually save a life.
Okay, just I want to address that point, but from a slightly different perspective. So rather than saying if they make a bad call, let's just say when AI makes the call, how do we understand it? And I think that was I think Marcus touched on it before. I think that the ideas of explainability or explainable AI, where we try to get a better understanding of how the algorithm made the decision or prediction that it did. But I want to add on to that another perspective called interpretability. Often these two words are used interchangeably, but I think of interpretability as tying the how to things like human values, right? Domain expertise and so on. And I want to add one more perspective to this, which is moving from explainability to interpretability to actionability, right? If we look at, so I've talked to a bunch of clinicians, and there are many clinicians here, but when I talk to them, one of the things that they tell me is, okay, you can tell me that, for example, my patient is at 5% risk of some disease or whatever, but what should I do about it? Can you give me a recommendation? So to me, I think when we look at AI in general, I think moving from, if we want to get adoption of AI, real adoption of AI in healthcare, we're going to have to start with explainability, move to interpretability, and on to actionability.
All right. Well, that's a fantastic point to end this session. Please join me in thanking the panelists and speakers.